13. Our work spans across India and beyond India in the countries of Afghanistan, Bangladesh, Maldives, Myanmar, Nepal, Pakistan, Sri Lanka, and Bhutan. The Institute has two giving us an opportunity to engage with them. We hope that we'll have more such engagements with you in future. And of course, a big round of applause to the Mithil Institute Delhi team for putting this event together. With that note, we can begin our event today, and I'll switch over to my moderator's role. As I said, I'll also be the moderator for the evening. And I'll just take a couple of minutes to introduce the panelists here. And first, I would like to invite the Harvard team to do their presentations. So we will have Professor Kavishwar Wagholikar, who is an assistant professor of medicine at Harvard Medical School. A brief bio of Professor Kavishwar. His research focuses on machine learning, on health records to assist clinical practice that's funded by National Institutes of Health. Kavi complete. In short, he goes by name Kavi. That's why you hear this name from Kavishwar to Kavi now. Kavi completed his MBBS, which is the medicine degree from the GJ Hospital in Mumbai, and did his PhD in scientific computing from Pune University with a fellowship from ICMR. He also did
I'm not sure if I can be heard, but if I can, no one's hearing the audio on Zoom. So the Q&A is full of requests to get the audio on.
I'm the Director of the Center for Control of Chronic Conditions at Public Health Foundation of India.
I think I can check with the.
Okay, Professor Vijay, can you hear us now?
Yes.
Okay, perfect. All right, thank you so much. And sorry to our Zoom audience that there was this lag in the audio. We didn't realize it till now that was an issue. So far what we covered was an introduction to the Mithil Institute, and we were introducing the speakers. What we can do is, for the interest of the online audience, we can maybe put up the short bios on our website and people can refer to them later on. I already introduced, the titles of each of them and the names. So I think you have them, and they were also in our posters, right? Okay, and I was doing the last introduction, not the least, for Professor Prabhakaran, who is the Vice President, Research and Policy and the Director of the Center for Control of Chronic Conditions at PHFI. He's an eminent cardiologist, epidemiologist, and academician of global repute. He moved beyond the conventional world of clinical cardiology to advanced science in the prevention of heart diseases and diabetes in India, so that his work could benefit millions of people in the country. He established large population cohorts in India, which have provided major insights in diverse domains ranging from epidemiology, biomarkers, role of nutrition on heart diseases and diabetes. Evaluation of task shifting and mobile phone-based solutions providing personalized patient management solutions and yoga care and cardiac rehab are two best exemplars of the low-cost context-specific solutions to enhance the quality of therapeutic and preventive care for chronic disease in India. He was applauded by the 2008 World Economic Forum report as one of the best worksite programs, and this worksite was a worksite wellness program that he designed with his team. Thank you so much, Professor Prabhakaran, for being here. And just for the online audience, I want to share that the format of the session is, which you did hear that I said earlier, that we're going to have a 25-minute presentation by the Harvard team first, and then we're going to get into a commentary by the two panelists here, Professor Prabhakaran and Professor Chandru, which will be followed by Q&A from the audience, both in person and online. So without further ado, I think we'll get started with the presentation. We'll have Professor Kavishwar.
Thank you, Monica, and our medical team, the Lancet Commission for organizing this. And we're very privileged to have you, Professor Dorairaj and Vijay Chandru. So quickly, okay. So once upon a time, long time ago, there was a woodcutter, and he had to cut a few logs of wood. A very strong guy. First day he cut 5 logs. Second day, he was just able to cut 4, though he tried harder. And third day, just 3 logs of wood, even though he tried like 4 times harder. What do you think is happening? He's putting more effort, but is not able to get as much output. What's going on? Well, he was not sharpening his axe. He was so busy doing his work and he was so motivated, he never sat down and thought out how he could do it differently. Is that what's happening in healthcare in the global south? There's huge volume, a lot of work, great work happening. But who is examining whether it can be done differently or in a better way? So electronic health records offer that chance to examine and get insights into the healthcare processes. Right? And there are three main healthcare processes. So we've got practice, policy, and education. As the healthcare process moves on, and this is like the key slide for today's talk. Like, so I want to focus, this is what I want you to focus on. How can EHR data be used to improve practice, policy, and education to achieve better patient outcomes? I'd like us to define what is the low-hanging fruit. What are the demonstration projects that we could do using EHR data? What are the challenges and solutions? And more importantly, who is going to do them? Okay, so let me clarify. What is EHR first of all? Electronic health record. As the healthcare process happens, the patient interacts with the physician, data gets accumulated passively. Okay? That is the electronic health record. It's important to say that there are different types of health record data: registration, lab, medications, billing, discharge, and notes. We don't have And in the global south, registration and lab and medication data, huge volumes are being accumulated. Now, often when we speak to people, they say we don't have data, but really what they mean is that they don't have notes. But there is billing information. That's a lot of information you can use for epidemiology. Okay. So there is first of all a lack of awareness of availability of data. So that's a challenge I feel, lack of awareness of availability of data. Secondly, overemphasis on interoperability. No doubt it is important, but sometimes that conversation can hijack, what can be done, and people are just caught up in how it's got to be done. And I think I don't need to explain to this audience, we don't need to talk about why retrospective EHR data, how does it compare with prospective data? Retrospective data is cheaply available, huge volume, but prospective data is expensive, and okay. So here, data is being collected in the health record systems, and there are these four stakeholders: clinical care, research, hospital operations, and policy. All of them depend on the programmer to access and analyze this data. And that is the biggest bottleneck. Right? Even though the data is there, these guys don't know how to access it and how to analyze it. They depend on this programmer, which is a very scarce commodity in healthcare institutions, which has been. So this is what is possible? What are the use cases? Let's talk about what are the use cases possible. Population health surveillance, improving. How can the data be used for operations? It can be used for accreditation, reporting metrics, even optimizing the hospital operations. No doubt for patient care, triage and admissions, and research. I would say epidemiology, data aggregation and analysis. Okay, so that's what we said. We define what is EHR data. We define the processes, what the outcome is, and here is where we are. We are at the bottom, and the goal is to go upwards. Definitely, the next step is to make that data accessible to the stakeholders, right, in a manner which preserves the privacy of the patients, right? And that's a population level analysis. So we know that's the next step, and the route to achieve success is long and tortuous. It'll happen. And I'd like, in the after the talk, like the experts, to comment on what the challenges are, who's going to do it, and what are the low-hanging demonstration projects. This is my list of, what challenges. We've been working for 2 years with with several institutions in India, and with healthcare associations and with the government. And what we realize that there are these three things: lack of awareness, as I said, lack of IT investments in IT in the hospital, lack of clarity of role models. Right? We don't have a culture. So even if this infrastructure is made available, will the stakeholders use it? Right? Will clinicians, will researchers use it? Because there's no role model. It's still looked down upon that, okay, if someone clinician does research, like, he's doing research because he's not good at clinical practice. Right? A little bit of mindset like that is there. And I think the way to solve it is value demonstration projects. So if you demonstrate value, then researchers, clinicians will take up more of analyzing what's the effect of their practice and how their practice can be improved. Hospitals will invest more in their IT infrastructure, and people will know that there is data and they can use it, and people will start using it for analysis. So let me stop. If I can give you a quick demo of how this looks like. Imagine that you are a staff or a faculty in a hospital, and apart from your electronic health record system, which you use to enter data, you have the system called I2B2, invented by Shawn here. So you log in, and what you see is a list of all medical terms that you can imagine on the left. Just waiting for this login to complete. Yeah. So staff which doesn't have IT expertise can use this interface to query data and get some insights in the data. So this is still loading. What you'll see on the left as this loads will be here, it's coming up. So these are all medical terms that you can ever imagine. They're arranged in thousands of terms, arranged in a hierarchy. So you can ask a question like diagnosis, circulatory system. You can go, as you open it up, it becomes more and more specific. Asking a question like, how many people had ischemic heart disease? So this is a demo data set. So it's going to give you the answer of 17. But if you're running it in a hospital system here, you might get like 170,000 or 17 million, something like that. So without knowing any IT, this intuitive interface gives you an answer, right? And you can ask a question. You can make it like, how many people ischemic heart disease? How many of them are males? Right? So think of a hypothesis, and you're able to use this interface more likely than not to get all you get back is a count. So you're not able to see individual patient data, but all you get back is a count. So you're able to do population level analysis. Now there are many efforts in this space. I2B2 is one of them, and I think very popular because of this interface. Okay, and I don't want to get into the tool, but this is just a tangible way. Imagine that a clinician can do this, a staff operational guy can do this and generate reports. So if we have something like this in our healthcare system, will it be used? That is a question. You've seen that. But it's also possible. It's also possible to connect. It's also possible to connect this system across hospitals, so that if you run a query, you get response from all the hospitals on that network. And Diane will talk about the networks that we have in the global south, in the global north. Okay, so let me stop here. I'd like to invite Shawn and Diane to talk about that. When they made the system available in the institutions there, how did it change? How did it change the ethos or how the workflows of people? And not only in their institutions alone, but when the federal government kind of adopted it, through projects, how did it change the state of research across the nation? What do you, Shawn?
Shawn is setting up. I'm just going to make a few comments. He's going to do the main presentation, but I'm going to just make it. Hi, can you hear me now? Yes, you can hear me. I'm just gonna do a quick lead in. We're gonna kind of go back and forth on this a little bit. So 20 years ago, when I was tasked with the position of supporting research for Partners Healthcare, which is a major organization at Partners, I didn't really know what that meant. I didn't really know what the researchers wanted. I was a CIO at one of our hospitals. I understood clinical and operational systems, but I had no idea what it meant. I'm not exactly even sure why they gave me the position to support research at the time. But what I found out was the number one, they wanted lots of things, but the number one thing that they wanted was access to the patient data to be able to find patients for their studies. And we couldn't give them access to our clinical systems because they really should not be, searching through our clinical systems without IRB approval. So we had to find a way a very basic way to allow people to query so they could fulfill their number one, need to be able to access that data. So I will, he's still setting up. So I think that's really important. It seemed like such a very basic thing to me, coming from a CIO position, because access to data to do reporting was important to the chief financial officer and the chief operating officer. So, giving the researchers access was important. It got more complicated, and the work that Shawn and his colleagues did kind of filled the gaps that my naive mind didn't really think about. But so Shawn, are you ready to?
Yes, Diane.
Okay.
So I've been very fortunate to have Diane and Kavi and many colleagues at Harvard University at first, and then across pretty much the entire US and internationally across in Europe, in Asia, and now in India. So we've been very fortunate to be able to bring this application to many folks so that they can take advantage of doing research using data that originates at the medical record. Now, the first way that we very first started to use this was about 20 years ago or so. We invented the Research Patient Data Registry. And what that is it was a database that was made up of about 9 million patients' data. And the data is arranged so that a data element such as a diagnosis or a medication or a laboratory and its value is in a very long table, which looks kind of like a timeline in a way, because that's how electronic medical record data comes in. It's like at some point in time, you get some fact on a patient. You put hundreds, millions, billions of these together, and you have a way to really go in and do research on patients. So what we did was we put that database together, but then the key is, like Kavi was saying, it doesn't really do much good, because the people who need to use the data the most, who are the clinical people in touch clinically with the data, who are going to be working with a lot of the researchers and computer scientists, can't get a feel for the data. So in order to fix that situation, we invented a query tool that Kavi showed you that can actually take all of the different types of events that occur with a patient and can put them together in this Venn diagram so that you can make, say, I want all the patients who have diabetes, are on metformin, and who have a lab value of hemoglobin A1C greater than 10. And that will give you a number, 200,000. Now, the reason it only gives you a number is because we're trying to protect the privacy of the patient. And so at this point, you're really just looking to see if there are enough patients with the right profiles to do a study. If there are, in this use case that we first adopted, you then go and you get all of the data by going through a very complicated, actually, workflow of getting permission from the hospital review board in order to get the actual data on the patients. But it allows you to get only the data that you need for the study after you've kind of learned that you have enough data available on those patients. And you can get it in files that you can actually put into your statistics programs like SAS or R or whatever it is that you're using in a format that makes sense. So that was really the key use case that started to drive what it was that we could do with some of this medical data. Now, I'm not going to go through this in detail, but there are many ways that we had to comply with regulations in the US, just like there's many regulations in India on using patient data. And so this process of using the query tool to look at the data without actually allowing individual patient data to come through until you go through that whole permission process was an important part of achieving this touch that now researchers, clinicians could have with all the data that flows through the electronic medical record. And what we found was that you can see at the top is the number of queries people are doing, and at the bottom is the number of data sets they're getting back per quarter from 2002 to 2019. And what I want to point out to you is it wasn't that people started to get data back and then it kind of saturated right away. Instead, it was a steady progression upwards, if not even a concave curve upwards. Why is that? And that's because people who knew how to use EHR data at first were very few. But as they communicated to others and got some of their students to use the data, more and more people then got educated and taught themselves how to use this data for research. And so it just kept getting larger and larger in terms of the number of people who knew how to use electronic medical record data to do their research. Until today, we have about $244 million of research agreements every year that use this data. But it didn't start that way. It started with a very small amount of people who knew how to use the data. But because it was made available in this tool, we could actually put people in touch with the data without, having to go and do a lot of learning before you actually use the tool. And that was the key to enabling people in the US to understand and use data like this for research and many other purposes as well. We invented a project that Kavi showed you called Informatics for Integrating Biology in the Bedside to organize that data in the database so it could be used by the query tool, but also so that people could invent new analysis modules. And so at the end of all of this, it really became a very large community project across the entire world to put new kinds of functionality into this system, which it never had to begin with. And that's all exchanged through this community website, community.i2b2.org. And there's over 250 implementations now across the globe of this system. Now, we've been able to take advantage of the fact that we have this system to do a lot of research and gain a lot of research funding. We were given this long COVID study, and what it does is it lets us conclude things about what it is that's happening to patients after they get COVID, where they're still suffering months, sometimes years afterwards. And so we are looking to characterize incidence of this problem, what the clinical course is, because we have kind of a timeline in our database, and what are some of the pathology and biological mechanisms, because we have laboratories and pathology and all kinds of data in here. And it's divided into different cohorts. It's about 40,000. And we both collect data elements using an application called REDCap over time on the patients, where we can actually organize all that data into a way that fits right into the query tool. And then we can do queries on, for instance, patients who are acutely infected were and had various attributes of long COVID. It also puts together data from many different places. So from a biorepository, from the electronic medical record, from sensors on the patients, from imaging that might be on the patients might have had done, and their red cap survey, such that you can use all the data together to do your studies. There's been other NIH initiated projects too, such as this NIH project called ACT, where it's used across 72 different hospitals in order to recruit patients for clinical trials. The All of Us research program based on genomics, and the imaging eMERGE program, which uses it for genomics. So the emphasis here is integration, right? Integration of different kinds of data, including EHR data, in order to answer important research questions, and computing what we call valid disease phenotypes, where we can actually present this as not just raw data, but data post-analysis. So you can use the post-analysis data in your research, just like all the other items. And that way, the community keeps building. So they keep building new analysis that produces more accurate data. And then people can use that in their studies. Then they can make even more accurate data. And this has been a really important part of how I2B2 has contributed to the world and community in general. Okay. Research industry collaborations have been important, and we can build things like different kinds of ways that we can report in public health systems using the automated runnings of thousands of queries, which can build stuff in these analysis programs out of things like just pharmacy and lab data. So even if you have not much, just pharmacy and labs, you can compute something like diabetes, and that will allow you to actually do the study based on the really great work that folks do in ways that they can induce data and new data types from EHR data types. So I think I'm going to stop here because we're running out of time. But I just want to emphasize that what this really promotes is a kind of a community approach to using EHR data, but with the proper protections in place so that the data from the patients aren't exposed without going through a very important and secure process, but it allows folks to exchange their ideas and use this data that's in the hospitals for the benefits of the patients.
I'm just going to make a couple of points, because I think we have a few minutes. One is Shawn talked about the fact that the hospital, Mass General Hospital, that there were $244 million of research per year that was being supported. I don't think he emphasized the fact that that wasn't the total amount of research that we do at Mass General. That was an amount of research where people said that they could not have done this work without that data. So it's research that would not have been able to be done in the past. So that's really important. The other thing that this tool has done for researchers is that because people have access to it, they're able to obtain new grants. So it's, a lot of times you'll get a grant because you have the right infrastructure to be able to support it. So it really has streamlined research in the US. The second example that I wanted to bring up was we talked about these networks that we're supporting. One of the things that the original focus of the network was to help find patients for clinical trials. I don't know how many clinical trials are done in India. I know that they'll probably start because clinical trials are so important. It is impossible to recruit patients. It slows down, it slows down clinical trials. It shuts down clinical trials. It's really expensive and hard because to find the patient and then to bring them in and to really go through that whole process is, it adds so much cost. So this network allows people to query across virtually almost the whole US. I think there's like a third of the lives of the whole US is within that network. So you can really zero in on finding the appropriate patient, which will give you a much better luck at recruiting those patients. So that's super important. And then the last thing I'll mention that this is kind of, COVID came at us really fast. And I didn't believe it. I was on vacation in Thailand and everybody had masks on. I couldn't believe it. So in March of 2020, it became quite apparent that we were in trouble. The world was in trouble. And people were dying. People were in hospitals and they were dying, and everybody knows that. I don't need to. It was only a couple of years away. So what we did was we went out and we pulled together many hospitals. Actually 300 hospitals across 9 countries, most of them using I2B2. And we said, we need to try to use the data, the hospital data, to zero in on the COVID patients and try to figure out, how we're caring for these patients. And so we did that within months within the pandemic. We were able to really rally people. And this network is called 4C, for clinical COVID. I don't know what it's these acronyms that people come up with. But we were able to pull people together and pull a lot of the data together to try to really zero in on these patients. It's a voluntary network. Actually, it's not even funded. It's still in place. They're still looking at COVID and long COVID. The hope is that network will stay in place and we'll start to focus on other diseases. They're talking a lot about obesity and diabetes. Anyway, that's what I wanted to bring to the table. And I want to be careful of time and turn this back over to the moderator.
Thank you. Thank you so much to the Harvard panel, Kavi, Shawn, and Diane, for those comments and elaborating on the platform and the virtues that it brings along. And I think, the way I was thinking, it's a great way to build data and rebuild data, like Shawn mentioned. And, what a way to bring practice to research and then back to practice in policy. I mean, such a loop that's being built through that data. I thought that was wonderful. And then, of course, you're building up a repository of information there, both at the individual and the community level, right? So anyways, those are just a couple of points that crossed my mind when I was listening to all of the presentation. Thank you so much. And I think without taking much time, I would like to invite the panelists to give their comments. Maybe Professor Prabhakaran, we'll go with you first, and then invite Professor Vijay.
So thank you very much. Right. First of all, congratulations to the Harvard group for that excellent presentation and giving ideas as to how to harness data that are being unused now. I come from a different world. For me, delivery and discovery are far more important in terms of trying to identify the mechanisms of disease and trying to get low-cost solutions. So data are kind of incidental there. I mean, we collect a lot of data in terms of creating electronic health records, as well as pairing them with electronic decision support systems in terms of providing better patient outcomes. So in terms of the challenges in India, I would say, first of all, it's fragmented healthcare. So we have different systems of electronic health records. In many places, you don't have true electronic health records. It's still paper-based, and you may not be able to get that data. The what is it called? I2B2 platform is an excellent platform, but we will run into regulatory landmines in India because there's an inherent suspicion of how we are going to use that data. Secondly, I was a little confused because you said that the I2B2 platform is anonymized. You're going to get anonymized data, but how are you going to identify individuals for clinical trials? That's a bit of a confusion I have. Maybe you can answer that a little later. The second problem is, why is EHR not progressed that well, despite there's a big push by the government? In fact, in the so-called health and wellness centers and primary care, there's a system that has been developed in terms of obtaining data for EHR, both in telemedicine portals as well as in direct patient engagement. But the uptake has been extremely poor. There's been resistance from the primary care physicians because they think they're overloaded with work. They might perfunctorily do some, just to create, what do you call, in terms of fulfilling the requirements, they might do, but beyond that, they won't go because there's a huge patient load over there. The second thing that has been suggested is task shifting, where we can use lower level healthcare providers like ASHAs and A&Ms and others who would collect the data, but they're also overworked. They also have multiple things to do. And so the quality of the data may be a bit of a problem. The third thing is, what about patients? Who is talking to the patients in terms of developing this databases? Are we consulting them? Because ultimately they need to give us permission to use their data, because they are supposed to be the ultimate owners of the data. And how do we get that data out of them? And how will I2B2 help us in terms of getting these data? The last point that I wanted to make is harmonization. How do we harmonize across various platforms and various thought processes that go behind this building of databases? And how do we link to other things beyond healthcare? Because the question that we posed in the title was harnessing database for population sciences. I didn't hear the word about social determinants, for example. How do you link social determinants such as air pollution with the health outcomes? So there are multiple benefits of getting this data, but I think we require a broader dialogue in terms of how do we harness and utilize this. In terms of the use case with the government, they have created a program for hypertension care and for non-communicable diseases care. And this is being done in collaboration with Tata Trust and Dell and All India Institute of Medical Sciences. A pilot is being conducted in Punjab where we are trying to look at three things. One is developing a good EHR for NCD care. Number two is linking to an electronic decision support system. And number three is establishing referral linkages both upwards and downwards and creating a patient-facing app so that the patient uses these solutions to their benefit. The pilot is ongoing, so we'll have some more results next year. Ultimately, congratulations on the humongous amount of work that you have done, but we need to look at both dialogue as researchers, but also digital dialogue as to how to get it to use in India. Thank you. I'll stop here and come back for questions.
Thank you so much, Professor Prabhakaran. I'll let the team decide, would they like to listen to the comments of both panelists and then get back to the responses, or would they like to go one by one?
It might be easier to go right to the answers, and then let me try to be very quick.
Okay, sure. Please go ahead.
So I think the first question was, how do you get to the identifier of the patient? And ultimately, there's a two-step process. The first one is anonymous, but the second one, after you've obtained the permissions, which you very clearly it's stated were very important, right? And that is absolutely critical. So you do the first step's anonymous. The second step, if you get the permissions, you get the names of the patients. The second was the quality of the data. This is very critical. And so what we've been working through is trying to collect data from many different kinds of, lab data, pharmacy data, radiology data, and synthesize it together so you can get a quality diagnosis. So you have evidence from many different places, not just one place. And patient survey data is very important, but it's another kind of data that you put together with this. The third one was getting permission from the patients, and that really so trying to work through the detail of how to get the right permissions in place in order to use the data is very critical. And so you're absolutely right. So we've kind of mastered it with a lot of sweat and tears in the US, but that would have to be created in India so that would happen properly. And then fourth was harmonization of the data. And that is something that's really important. Ultimately, think of everything can be thought of as some kind of a event about the patient or idea that's being stated about the patient, whether it be that they have hypertension, whether it be that they're on metformin, whether it be that they have a positive lung scan, whether it be that they have a certain variant in their genome. All those are things that we discover over time, at a certain period of time. And so I2B is essentially just a long timeline of all those events for millions of patients. And that helps harmonize data from very many different venues into one kind of big table that we can query from. And then finally, I think there's a great question about how do we combine things like environmental data? And that is really important. And what it does there is it tries to link it. So for example, if we know, often we know where the patient's living, not only now, but before, because we keep all that data in memory as they move around. And then we get the environmental data, which is also linked to an address. And then that's how we can put that kind of data together. But we do need that linker, whatever it might be. So those are really great points.
Thank you, Shawn. I don't know if Kavi or Diane.
Can I just want to make one quick comment about the adoption of EHRs in India. And it's not really about EHRs in India. I just want to tell you that it was not easy. It is not easy to roll out an EHR. Physician adoption, we had the same problems with our physicians. It is extra work. I mean, you really have to make sure that you try to create a workflow that is not too overburdensome. It took many years for physicians to finally accept the fact and understand the fact that it's beneficial to them over time, the next time the patient returns, but it was not easy. The US government mandated that hospitals must implement an EHR by 2015. So there was the big rollout of EHRs. Some of them didn't go that well. And so once they were in place, they found out that a lot of the software and a lot of things didn't work well. So they had to implement a new mandate, their new initiative called Meaningful Use, where they had to come up with criteria to prove that the data that was actually being collected from an EHR was actually usable. So it's been a lot of work to get it right. And we're still going down that road. There's absolutely no question. But definitely we've suffered through it, and I think we're getting to the point where people, physicians want to use an electronic. They assume that they're going to be using it, but it took a really long time.
Great, Kavi.
It's about the point of EHR not progressing. I want to take a different point from Diane. Actually, I think the West has made a mistake of turning doctors into clerks. And shouldn't, and probably and here it's not practical because the volumes are really huge. And is it possible to reimagine it? And so for example, the lab data is entered, registration information is entered without the physician doing anything. Can the physician be restricted to just a small set, maybe just medications, right? And obviously even getting data from the patients directly, right? So I think things can be probably done differently, and we got to find ways on how to leave the doctor alone. And I think instead of waiting for all the data to get accumulated, what can be done now? Now there is, if you go to any mid-tier hospital, there is billing, there is lab, probably there is medication information in the system, there is demographic. That's enough for 90% of the epidemiology. Yeah, so I think we don't have to wait, for EHR adoption at the institution level. But my question was about culture, right? Even if you make the system available, from your perspective and the projects that you've done, the capacity building, the role models, and you are the role model And how can we have people follow your footsteps on the kind of stuff that you've done?
Maybe I should give a chance to Dr. Chandru to answer, and then I'll respond to your question, because these are very important questions that you have posed, and I'll give you some examples of case studies. But over to Dr. Chandru.
Yeah, I think we can just move on there, because I thought there was one great point which, that Professor Prabhakaran you made, which was about the whole load on the healthcare workers, and I think that largely comes from the whole private sector versus the public health system, the way, the public health sector delivers even to the level of tertiary care, which puts in primary care, secondary care, tertiary, and it puts a lot of loads, on the field workers. So I think that's where, a lot of data potential lies in, which was, I think I want to circulate back. Maybe we'll have Professor Vijay Chandru. Professor Vijay Chandru, can we have you comment, on the presentation?
Sure, thank you. And I really enjoyed, the presentations and the conversations up to now. You're right in pointing out that I do think from a public health or a universal healthcare perspective, which is what we are looking at from the Lancet Commission, the Citizens Commission for Reimagining India's Health System, that we'll have to think about electronic health records in a, and that is more relevant to our health system. And I think Dr. Prabhakaran, just pointed out how the world's largest NCD study that is going on with the ministries and the public health researchers and Dell Foundation and several others involved is evolving, new systems, and I think, but the ideas behind I2, B2, and being able to extract epidemiological information, which I think was nicely demonstrated in the case of studying, say, long COVID and so on within tertiary centers, I think is a good lesson that could be applied in the Indian context, and perhaps some of the clinical researchers listening in are picking up some of that. I did want to raise just a couple of technical questions as well. I think from what I understand, most of Partners runs on Epic, and as your electronic medical records system, I think Beth Israel probably is an outlier, but so is I2B2 primarily built on top of Epic, or does it work with multitude of systems, whether it's other types of EMRs, right? And that's just a technical question there, and I think the idea that we could leverage this to get a better understanding of some of the ailments that show up in our tertiary centers. The one complication is, of course, that it's not necessarily a captive group of patients. So how do you get time staged information, particularly when you have patients who have been treated in a primary healthcare center and then triaged and sent in to the tertiary centers? That flow of information is much more challenging to keep track of, and I just wondering if that is how the Partners program, for example, works with community health centers, and how that flow of information is managed across the heterogeneity of health delivery systems. So I'll just add these couple of questions, and maybe the conversation can go forward. Yeah, look forward to responses.
Great. I don't know who among the Harvard team would like to start with the response. Shawn? Okay.
Sure, I can start. Beginning with the question about Epic. So actually, Epic wasn't around when we invented I2B2 at all.
Okay.
It was put in later, but really I2B2 can adapt to any medical record system, because no matter what the tables look like in the medical record system, I2B2 wants a big long table of facts to be extracted from it. So that ultimately, it actually operates not only on a medical record system, but on a patient survey system and other forms of collecting data on patients. Now, you bring up a really good point about continuity of care. And if you want to do a study, how are you going to know that you've captured all the data that's available on the patient? Now, it turns out at Mass General Brigham, we actually include the community health centers in the mix. But in general, patients do have the options of going to various healthcare centers. And the way that we are able to study patients is that we actually try to concentrate a set of patients who are what we call loyal to that healthcare center. So that allows us we can't use all the patients often in our studies, but we can calculate at least because we know like what tests should be given in patients and how often they should be going and seeing their doctor. We can calculate which patients we think are loyal to the system, and then we have and who we have most of the data on those patients. Very good question.
Right, and I think one of the reasons I asked that question is some friends from CMC Vellore just had sent me a paper that talked about in the UK at the National Health, the NHS record actually offer a very good way to even apply things like hidden Markov models and so on to see progress of disease and so on, because of the availability of time-staged electronic health records for across the entire population in some sense, because of the national health scheme. So I get what you're saying, that you have to stay with the loyal population, or I guess hospitals like Kaiser Permanente and so on with managed care would have a captive population that on whose records they'd be able to work. So.
Great. Kavi or Diane, would you have any comments?
Do you want to come back to the question I had? I mean, till now we kind of agreed that this is important, and we've agreed like what are the use cases or questions to go after, some of the challenges, but who is going to do it? I'd really like to hear your thoughts on.
So let me give you an example. I think there are multiple things that are important when you're trying to disrupt a system or change the system. I think first is the cultural context. And just to give you an example, we tried to do task shifting with nurses in terms of diagnosis and management of hypertension and diabetes in community health centers. And we got nurses who were willing to do that, and we appointed them on a research mode. And when they were appointed and when they were called nurses, the system doesn't understand. The system says nurse is a nurse. She has to do bandaging, she has to go give injections, she has to take inpatient care and so on. So we simply changed the nomenclature and called the nurse an NCD care coordinator. And that actually helped the whole system, because that person, the person was used for task shifting was used for that particular purpose. The second thing is, how did we overcome doctors' resistance? Doctors never used the tablets, whatever we gave them, because they said we are overworked, we don't want to put this in. So we train the nurses, train the community health workers, they put the data in, and they went with a printed report to the doctor. I mean, now doctors are using the tablet so that at least they see the report. But in the initial phases, we had to give them paper report. The second thing was, apart from the EHR itself, we provided them with a decision support report, clinical decision support, which provided personalized patient diagnosis as well as treatment plan, which we were surprised that the doctors accepted, even in tertiary care. So we did this trial in 10 tertiary care centers in management of diabetes and showed that at the end of 5 years, the risk factor control was 2 times better in those who use the electronic decision support system. So the EHR has to be paired with a decision support, and it has to be a composite of everything. I mean, EHR cannot exist in isolation. Somewhere we have failed also in terms of taking patients into account. I think these have to be patient-centric. Patients have to be involved in the development of EHR systems as well as electronic decision, because they will start owning, compliance will improve, the community will get engaged. And we are looking at a trial where we are co-designing these interventions with the patients, and we are going to roll out a cluster randomized trial soon. The last problem is we have been very vertical so far. We are treating hypertension, we are treating diabetes, we are treating COPD, but patients are not like that. They have 2 conditions, 3 conditions. They have osteoarthritis, they have peptic ulcer, they have backache, they have diabetes. How do you integrate that care? So you require to look at multiple long-term conditions together, even when you design your EHRs. So if I had to summarize, and you have to reimagine health system, because that was the title, I think we require to address the issue of culture. There has to be culture sensitivity. It has to be context specific. Something which works in Kaiser Permanente may not work in other situations. So we need to contextualize that. It has to be equity promoting. If it is going to address only the elite and the population, it's not going to help. Then it has to be cost and cost effective, so the governments, the service care providers accept that. And lastly, we need to look at how to include social determinants. I'll stop here.
Yeah. If I might just add a quick comment, I think Dr. Prabhakaran has actually captured it very well, but let me also just point out that India does have an opportunity to really reimagine its health system. And to some extent, I think, the creation of the India Health Stack, the National Digital Health Mission, and projects like the big NCD project going on, I think are now gradually starting to give us ideas on how to essentially build systems leveraging technology in a slightly different way than perhaps countries with legacy systems have had to build their platforms. And I think I will also just point out that I think we should also be exploring much more how user interfaces are set up. I think particularly when we get community health workers involved in actual data gathering and also in delivering certain types of I would say clinical measurements. The user interfaces would have to be suitably defined, and the use of speech interfaces, so on, which actually, in many ways, some of the early AI research in the West with people like Kurzweil and others who were looking at medical systems were proposing. I think many of those technologies today are perhaps ready to be deployed at a different scale. And so I do believe there's also a very new way of thinking about how technology enables the reimagination, and I'll just leave it at that because I think this is still work in progress. So, yeah.
Thank you so much, Professor Prabhakaran and Professor Chandra, for summarizing it so well, putting it all in the context. I think that was wonderful. Unless any comments from the speakers, I would like to, open the floor for any questions from the audience. Anything from the speakers' side? No? Okay. All right. So we'll have last 10 or 12 minutes. We'll first open the floor to questions from the in-person audience, and then we'll go back to the Zoom questions. If you have a question, just introduce yourself, but first put on the mic and then put your question. Anybody in the room? Please go ahead. Yeah. Introduce yourself and then just the question.
Hello, good evening, everybody. First of all, thank you for a lovely discussion. My name is Parth. I'm a physician and I'm also a fellow in this Lancet's Commission. My question is from a very patient's perspective. Like Prabhakaran sir mentioned, patient is who owns the data. So does I2B2 offer the option to the patient to download their own data and access it?
So that's a great suggestion. No, but just because nobody has built a plugin to do that. Now, the key would be you'd want to make sure the patient identified themselves properly, right? That's the part. But one could work through that. And then now the All of Us program does have this initiative to return data to the patient that's collected. So there is a precedent for doing that.
I just wanted to add to what you said. I think there are approaches like, Bitcoin is a horrible word now, but there are techniques in Bitcoin which they use the blockchain technique that can actually kind of ensure privacy as well as ensure security. And one could think of ways and means of doing that.
Great.
Thank you, sir.
Yeah, thank you. Any other questions, sir? Please go ahead.
Thank you for this wonderful discussion. My name is Rajiv. I'm an associate professor in computer science at Shivnadar University and work in the area of machine learning applications in the field of medical imaging. So one of the biggest challenges that we face is the size of data. It is so small. And any generalization which is based on such a small data, particularly from Western nations, becomes very difficult to apply in other context. And in a country like ours, it's a amalgamation of many countries. There can be regional patterns. Unless until we have data from those places, it's very difficult. That's one issue that we face. The other is longitudinal data that I think you talked about, which traces a history. And that's very difficult because different things are logged in different places and they don't talk to each other, right? So is there a way that you are addressing these issues?
So the first one, I'm not sure I totally understood. Is it when you say when you're saying that this is small data, are you referring to the fact that imaging is large data or big?
No, so imaging is very small data. Particularly the data which is available in the open domain, very limited in terms of size. And there's, based on that amount of data, for example, COVID, while the entire world was suffering, the amount of data available in the open space is still very small to make generalizations.
Right. So I guess the key part there is trying to make use of what you do have. Because it's true, there's many ways that you can imagine better ways to collect data, but in some ways that's just a dream, right? So focusing on like what is there, and it turns out a lot of times there's a lot more that you can derive from that data. So if you have a set of test results, for example, if one of them's the COVID result, both of positive and negative, you can then infer that the patient has the disease COVID. Now, I know that seems simple, but that's a big step, right? You went from a test result to actually inferring a patient has a disease. In the same way, you can say, well, if a patient had a hemoglobin A1C greater than 10 and is on metformin, just by knowing the labs and the pharmacy, you can infer that they have diabetes. And so you can put that down as a fact on the patient. And so by being able to infer some of these things from images as well, and you can kind of get a more complete data set on the patient. And those do rely on a lot of machine learning in order to try to figure that out. So you take a bad situation, which is you have a very little amount of data, but you apply some high technology to it, and you can actually come out with a really interesting data set.
Just wanted to add, I think when we look at data, we have to look at two things, spatial and temporal. Many of us talk about spatial. If you get temporal data, like for example, if you have a data of 200,000 patients, and if you have the data for 4 years, it becomes 800,000 person years. Obviously, it's going to become more powerful. It all depends on I don't think it's actually the number that matters. The amount of phenotypic data that we're going to collect matters. Like the UK Biobank, for example, has given us enormous insights, including Mendelian randomization patterns and other things. For example, we are working on air pollution and linking it to health outcomes. For that, we require a computer which had to be customized and fabricated, had to have close to 10 terabytes of space. So it all depends, ultimately.
Any other questions from the audience? Please go ahead. Put on your mic and introduce yourself. The red button, the button down.
This is Piyush. I am a PhD student in economics at JNU. So I was asking, like, we are thinking about research and like treatment perspective, but about privacy. In India, a lot of poor people are there; they are uneducated. So we are not able to see from their perspective. Like, suppose someone has abortion or some HIV things, they might not want to share with the doctors. I mean, it is their choice to share or not. So how can we ensure that their choice has been respected?
Maybe I'll take a stab at this. The way the National Health Authority is designed, the India Health Stack, the Ayushman Bharat Digital Mission Stack, the patient actually, will actually have control over which of their test results and so on they communicate to the provider that they go to, right? So there is technologically, solutions being built so that they could control the information that is passed forward. So technically there is an answer to this. However, what will happen in practice, has to be seen. But these things can be enabled even, through biometrics and so on. So that this is not necessarily, foregone conclusion that they will lose their information and right to privacy. Right to privacy is a fundamental right. And so any technology that we construct has to take into account all of this privacy preserving capacity as part of our techno-legal solutions infrastructure that will be created. And that's part of this reimagination. So I'll just thank you.
Thank you so much, Professor Chandra, for your response. And I think in interest of, also the online audience joining us, I want to ask the team if there is a question online from the Zoom audience, and if you can just share it. One of you can just read it, I think.
Are we also considering the end user of this digitized health records, as the education level and access to the technology varies across different strata of the economy? And how are we going to make it user-friendly without compromising on the confidentiality of the data collected?
I think it's partly answered, but yeah, I'll let.
So I think one point we didn't touch on, and which is very important, that imagine if a system like this interface to understand the EHR record is made available in the hospital. How will it affect education, right? medical students, instead of having to read books from the north and look at the epidemiology of the north, you can actually see what's going on in your hospital, right? And understand the local patterns. Will totally change the way medical education happens. Right. I think, and that's what I think she's trying to get at. And the technology here is about how to make that analysis possible, how to enable clinical students, faculty, staff to ask these questions, how to empower them, basically how to empower them to ask these questions so that they can understand what's going on. Right now, what's happening, people feel helpless. Clinicians feel helpless. They want to improve. They want to understand how is the care that they are giving, how is it affecting the patient, but there's no way they can see the big picture or influence the big picture. Making this record accessible gives them the opportunity to generate insights, right? And I think it'll have so the system in the West, the way it has been used is been for cohort identification for trials. But I think the same technology here has got a totally different dimension because of the public health infrastructure or even clinical. This I wouldn't say I don't call it research. I'm calling it having a scientific temperament. Right? Clinicians will be able to have a scientific temperament, and we'll be able to bring more of questioning, empowering them to question the system. And I think that they are the ones who really can reimagine the healthcare.
I think a lot of awareness point, I think that also you're touching upon it, like building awareness. I don't know if Professor Prabhakaran, Professor Chandru had any response, comments to anything.
I think this has been brought up and you
Right.
actually answered everything. So nothing from my end.
Okay. Any other questions from the audience on the floor? We're about time, so okay. All right.
So I saw the National Digital Health Mission policy. The patient can partially share their details with the healthcare providers. But however, the power asymmetry between the doctors and the patients are so large, they have to be forced to share the details.
That is true. I think there is a lot of information as well as power asymmetry. But what happens in non-digital practice when you're directly seeing patients, you obviously give that information. It's supposed to be confidential. And similarly, I think we should maintain the confidentiality if you're doing telemedicine or digital. So there's no difference between in-person consultation and telemedicine consultation as far as ethics is concerned. It remains the same. Patient confidentiality is paramount.
Thank you. Thank you so much for those questions. And let's end with a round of applause for all the speakers and the panelists. Thank you so much, audience, for joining us today. We'll just wrap up the session, but I think the speakers and panelists will be available for some time in case you want to interact with them or have a question one-to-one. But thank you all for coming in on a Tuesday evening. I know it's a rush traffic time, so thank you so much for joining us. And thanks to the team here, both the tech team, from the IRC and outside, and our team here at the Mithil Institute.